Welcome to this Clinical Care Options and Practicing Clinicians Exchange podcast. I'm your host, Courtney Duval. Today's episode features a discussion on strategies to address social determinants of health in non-valvular atrial fibrillation. This episode is part of a larger educational program titled The Biggest Risks to Cardiovascular Health, Addressing Social Determinants of Health in Non-Valvular Atrial Fibrillation. During this podcast, Dr. Keith Ferdinand, Professor of Medicine at Tulane Heart and Vascular Institute and Tulane University School of Medicine in New Orleans, Louisiana, and Dr. David Kountz, Professor of Medicine and Associate Dean of Diversity, Equity, and Inclusion at Hackensack Meridian School of Medicine in New Jersey, discuss a patient case that highlights how health disparities can impact non-valvular atrial fibrillation management and strategies to address these disparities to improve patient care. For more information about Dr. Ferdinand and Dr. Kountz, and for a link to the full online educational program, along with a CME, CE certified on-demand webcast with downloadable sign sets and a clinical thought commentary, please visit the show notes for this episode. Now let's get started and hear what Dr. Ferdinand and Dr. Kountz have to say about addressing social determinants of health in patients with non-valvular atrial fibrillation.
I'm here with my colleague, Dr. Keith Ferdinand, a cardiologist from New Orleans, Louisiana. Keith, good to see you.
Hi, Dave.
So we're going to discuss a case of a patient you cared for involving non-valvular atrial fibrillation and some issues related to social determinants of health and maybe a few other issues.
Sure. Well, this is an older African-American woman with long-standing uncontrolled hypertension who developed atrial fibrillation. I did a CHA2DS2-VASc score, and she met the criteria for anticoagulation and started on warfarin. Now, why warfarin? Well, she had not yet gotten into the Medicare range. She was 64, but she did have hypertension and diabetes, so the CHA2DS2-VASc met criteria. But her insurance company balked at giving her a non-novel oral anticoagulant, or what we now call a direct oral anticoagulant, or DOAC. So I tried warfarin, and it was really difficult. Her INRs would swing wildly from subtherapeutic to supertherapeutic and get as high as 7 or 8, often have to hold it. One time she had to take oral vitamin K for a couple of days. So I just think it was really difficult.
So what are some lessons learned that our colleagues can take away from this particular patient?
Well, one thing, we know that atrial fibrillation is the most common of arrhythmias. It's seen in older persons, and she had multiple risk factors, including the presence of hypertension and diabetes. But we also know that while warfarin has a long history, it's often difficult to use. And it can actually be somewhat toxic. Patients can bleed, and the bleedings can be fatal at times. And on the other hand, subtherapeutic levels is also very common. So perhaps what we need to do is that if we decide to use warfarin, recognize these barriers, but also for patients who may benefit from the direct oral anticoagulants, do something to assist them with getting access, perhaps having a relationship with a pharmacist who knows how to get into some plans or some programs where they can utilize a medication that perhaps they can adhere to more safely.
Dr. Ferdinand, how would you help your patients access the newer oral anticoagulants?
Well, first of all, warfarin is cheap. It's readily available. It's been around a long time, and it is effective. The problem with warfarin is that many times the patients are subtherapeutic, and then they're over the therapeutic range or super therapeutic. The data now are pretty convincing that the direct oral anticoagulants are more effective in terms of maintaining the person in the therapeutic range and appear to have less incidence of major bleeding and are as effective as preventing stroke in patients with non-valvular atrial fibrillation. And the DOACs are easier to maintain in therapeutic range without having any excess in bleed. So now the next question becomes cost. And we know cost is a real barrier to care. Although she was older, did not yet have Medicare, so that she did have a problem accessing the medicine. There are two things that you do. One is, if they do have insurance, some of the plans will selectively tell you which of the DOACs is available. Secondly, I already partner with pharmacists. We have a pharmacy within the hospital building itself. I know the pharmacists by their first name. and they will tell me some of the plans or programs in which even more expensive branded medicines can be achieved at a very reduced cost. So they will often help the patient. I'll say, well, I'm going to electronically prescribe it, go down to the pharmacy, and they'll give you some coupons, or they'll give you some ways in which you can get access to the medicine at a fairly heavily discounted cost. Takes a little effort, takes a little time, but remember, we're talking about a potentially life-threatening condition, and we're talking about a medication with warfarin, although superficially it appears to be cheap and inexpensive. It has real costs too, and oftentimes the patients are not in therapeutic range.
How do you perceive patients respond when you're recommending stopping something they may have taken for a long time to a newer medication? And are there any, you've described a lot of the positives, are there anything that a clinician should look out for in terms of side effect profile, dosing, if they're not as familiar with some of the newer agents?
Well, we know that the newer agents are overall as safe and perhaps even safer for major life-threatening bleeds. There are some changes in dosing related to advanced age and renal function that you should be aware of. But in general, I think the patients are happy when they don't have to come to what we call Coumadin clinic, and I manage a Coumadin clinic here at Tulane, where every week to 2 weeks they come in to get blood drawn, and if they have a home unit, stick their fingers and then call in numbers. It becomes pretty complicated. The newer agents, really easy to use. Because of your age or your kidney, we're going to adjust the dosing. But other than that, we don't expect you to have any more bleeding that you would with warfarin. In fact, we're going to maintain you within therapeutic range on a more consistent manner. And you can eat your greens and your salads. Patients love that.
So, Dr. Ferdinand, do you think that health literacy or lower health literacy was a factor in this patient's situation? And if so, what are some of the strategies to help address or overcome low health literacy?
Well, we know that low health literacy is clearly a factor. This was an African-American woman. If she had been a recent immigrant, perhaps English would be her second language. And that is a clear marker for an increase in risk in using warfarin and some of the more potentially toxic medications. What do you do to overcome it? Well, if English is the second language, you need to have a valid interpreter available. On the other hand, even if the person speaks English, they may not understand some of the fancy, long Latin-based information that we're trying to give them. So we need to use simple language, culturally appropriate, literacy level appropriate. I often tell my students, I'm here at Tulane in New Orleans, sit down, eye level, talk to patients in a very respectful manner, do what we call teach back, where you ask the patient to explain to you what you just told them, and then pause and ask, do you have any other questions? And I know that doctors and other clinicians are somewhat hesitant to open up that Pandora's box, but really we've done studies, and it doesn't add much to the visit, but it gives the patient a sense that you're really interested in their welfare and you're willing to answer questions that they may have.
These are such good practical tools. Like you, I teach trainees here in New Jersey. They are often proud to use medical jargon, and I need to remind them that's not going to help them at all, not only with a low health literacy patient, but with all patients. So to use plain language and not rely on the 11-year-old granddaughter to be the interpreter. That's inappropriate. We all have access to high quality translation tools and devices today. And we really need to take advantage of those tools for patients for whom English is not their primary language.
You know, those are some very important points. When you look at cardiovascular disease, and I'm a cardiologist, we know that it contributes to what I call the white-black mortality gap. And this was described early 2002 in the landmark Institute of Medicine publication known as Unequal Treatment. This is not social science. We're talking about death, mortality, where Black Americans die more and die prematurely from cardiovascular disease. And it's primarily driven by poor control of risk factors. So in this particular patient with atrial fibrillation, not only do I need to do better to control her blood pressure and her diabetes, but to get her evidence-based therapies and to assist with her getting access to those medicines and then making sure she understands how to utilize those medicines.
One other potential strategy is to use non-healthcare providers to help with the messaging. So this could be family members, this could be with their consent, someone the patient identifies in the community or in the home setting. It might be in your office, a medical assistant or a nurse. So besides the effort that you put in, can we rely on others to help get this word across to patients like this?
Dr. Kountz, thank you for reminding that it really is not about me as the physician, it's a team. And the team is well beyond the physician or the nurse practitioner. It extends to the pharmacist, and it extends to the significant other and support persons that that person has. You know, HIPAA doesn't say that you can't ask this patient, who brought you today? How did you get here today? And sometimes you'll be pleasantly surprised that that person who's quietly waiting in the waiting room is a nurse or a teacher or a lawyer or an accountant who's taken off that day to bring his or her family member to the physician. They can help in terms of bridging some of the literacy gaps, the understanding, the adherence questions that we have. So the team approach is the best approach. And while I spoke enthusiastically about what I do as a physician, that certainly is not the whole story.
Dr. Ferdinand, thanks for this very interesting case discussion. As we summarize, what are some lessons learned for our colleagues with regard to this patient's situation?
Well, perhaps I'll give two take-home messages. First of all, recognize how common atrial fibrillation is and adjust your therapy if you need based on age and renal function, but also know that if we don't use anticoagulation effectively, these patients are at high risk for stroke. The second thing is have a relationship beyond the clinical practice, extend out to the pharmacist in terms of telling the patients where are some of the means in which they can get a lower cost of the more expensive medications, the direct oral anticoagulants. They know the tricks, they know the trade, they know the coupons and the different programs that are available. But clearly, because warfarin is readily available and relatively inexpensive, because of the need for the frequent INRs, the restrictions in diet, the large amounts of time the patients are out of therapeutic range, I think DOACs, in a way, are the way to go for modern medicine.
Great. Thank you so much for this interesting conversation.
Thank you. Always like talking to you, Dave.
Thank you very much to Dr. Ferdinand and Dr. Kountz, and thank you to the listeners for joining in. We hope you have enjoyed this podcast and invite you to listen to our other podcast covering more strategies to address social determinants of health in non-valvular atrial fibrillation if you have not done so already. As a reminder, to view the full program, click on the link in the show notes for this episode. As always, thank you for listening.